I will first invite Dr. James Fung, who is also very well known. He's a young man, but he is the first transplant physician trained in Hong Kong. And he is a consultant hepatologist as well as gastroenterologist in Queen Mary at Hong Kong, which is the most famous hospital in the region. And he has sentinel work in this area in the transplant hepatology. And we are all eager to listen to him. Dr. Fung, please. Thank you very much. And it will be a great privilege to learn from you. Dr. Fung.
So thank you to the organizing committee of the Transplant Hepatology course for inviting me to participate and speak on the topic of long-term impact of immunosuppression. I have no relevant disclosures. So when we talk about the long-term impact of immunosuppression, this is really a testament to the efficacy of immunosuppressive therapy in preventing rejection and preserving graft function so that patients are surviving longer and therefore are susceptible to the long-term effect of immunosuppression. And when we refer to the long-term impact of suppression, we are usually referring to its detrimental effects, which can be divided into class effects, which is the overall effect that can lead to the development of opportunistic infections and also de novo malignancies. Then there are these specific drug effects which are inherent to each class of drugs, which includes the calcineurin inhibitors, which may cause renal impairment, metabolic syndrome, lead to osteoporosis. The M2 inhibitors can lead to renal dysfunction with proteinuria, metabolic syndrome, of course, and also interstitial lung disease, steroids, well-known adverse effects, including osteoporosis and also a metabolic syndrome. Now, I have put operational tolerance as a query here, but the achievement of operational tolerance is probably not directly related to the use of long-term immunosuppression. So I will go through each of the components in the next 15 to 20 minutes or so. Now, this table shows you the common infections in solid organ transplant recipients and stratified by the different time periods after transplant. The types of infections in the early post-operative period are largely related to complications from procedures, such as catheter infections and also wound infections and so forth. When you go beyond the initial perioperative period and into the long term, the immunosuppression that is usually reduced to much lower levels, and the risk of infections become less, although likely still higher than the general population. So the risk of infection decreases with increasing time from transplant, and other complications such as malignancies will become more common. Now, with long-term immunosuppression, the infections most commonly observed are the typical community-acquired pneumonias, which can occur in a significant proportion of patients after transplant. And the common bacterial pathogens include Streptococcus, Haemophilus, and also some of the atypical pathogens such as Mycoplasma. Now, liver transplant recipients are also at risk of influenza, which occurs at a higher frequency in all solid organ transplant recipients when you compare them to the general population. And if infected, they're more likely to get complications, and therefore yearly vaccination is still recommended and is effective. However, the seroconversion rates, of course, are lower than the non-transplant individuals, and breakthrough infections can still occur. For late viral complications, herpes zoster is probably the most commonly reported infection. When we talk about reactivation of hepatitic viruses such as hepatitis B and hepatitis C, this is rare nowadays with the use of highly effective antiviral therapies. Now, another commonly observed phenomenon after transplantation, of course, is renal impairment. And from this earlier study of almost 70,000 non-renal organ transplant recipients from the US, you can see that chronic kidney injury is very common after liver transplant, with 50 to 60% having stage 2 to 3 after 5 years, and a cumulative incidence of up to 25% for stage 4. And when you look at the incidence of chronic kidney failure in liver transplant recipients, you can see that it's higher than heart or lung transplant patients, despite probably needing lower doses of immunosuppression. Now, this may be multifactorial, and the post-liver transplant renal function is affected by pre-transplant factors, including pre-existing chronic kidney disease and also the occurrence of hepatorenal syndrome and also acute kidney injury, and also in the perioperative period where there's a risk of developing acute tubular necrosis. And finally, post-operatively, of course, with the use of long-term immunosuppression and also the onset of diabetes and hypertension. And all of this cumulatively will result in what the final kidney function will end up to be. Now, on the left side of this slide is a diagram shows you the pathophysiology of CNI-induced renal impairment in both the acute and also the chronic setting, and the effects on the different compartments, including the glomeruli, the arterioles, and also the tubulointerstitium, ultimately leading to a reduction in renal blood flow and also the reduced GFR. Now, the chronic changes with long-term immunosuppression includes interstitial fibrosis, tubular atrophy, hyaline thickening in the arterioles, and also glomerulosclerosis. And on the right side is a summary of randomized controlled trials and also meta-analysis looking at the effects of different immunosuppression usage on renal function, and essentially non-CNI or delayed CNI use is associated with an improvement in renal function in these studies. Now, rather than these immunosuppressive agents having any direct favorable effects on the kidneys, it is likely that the improvements observed is a result of lower CNI dose or CNI minimization. And as liver transplant recipients are living longer, perhaps one of the most notable consequences is that more and more will have underlying metabolic syndrome, including obesity, diabetes, dyslipidemia and hypertension, and also post-transplant metabolic syndrome arises in roughly about 40 to 60% of liver transplant recipients, which is roughly double that of the general population. And on the left side, you can see the incidence of metabolic disease prior to transplant, the risk factors with these diseases, and the post-transplant incidence, which is generally higher than the pre-transplant levels, especially for diabetes and also for hypertension. The risks for the development of metabolic diseases are multifactorial, and these include genetic susceptibility in patients with pre-existing metabolic diseases, the presence of sarcopenic obesity, and of course the effects of immunosuppression, of which steroids, CNI, and mTOR inhibitors are really the main culprits. Now, this slide shows you the proposed mechanisms as to how these three agents can promote development in metabolic diseases acting on the various different organs. For instance, hypertension can occur as a result of increased vasoconstriction, reduced vasodilatation, and also reduced sodium excretion. Diabetes can occur as a consequence of reduction in glucose uptake by the adipocytes and also the myocytes, increased glucose production within the liver, and also a net reduction in beta cells in the pancreas. Now, not all agents have equivocal effects on the metabolic diseases, and this table will show you that some agents will have more detrimental effects than others. For instance, for hypertension, CNIs have more effect than steroids or mTOR inhibitors, whereas mTOR inhibitors will have more effect on dyslipidemia than other agents. For diabetes, steroid is the most diabetogenic, which is then followed by CNI. And so from this, the clinician can decide on the type of immunosuppression based on the risk profile of the patient. Now, even within classes of drugs, the risk of metabolic diseases and adverse effects may not be equal. With CNIs, for example, cyclosporin is associated more with hypertension, dyslipidemia, and also hyperuricemia, whereas tacrolimus was more associated with new onset diabetes after transplant. And in a recent meta-analysis of post-transplant diabetes after liver transplant published this year, the proportion of patients who developed post-transplant diabetes by 2 to 3 years was 0.15 for cyclosporin, 0.23 for tacrolimus, and 0.27 for sirolimus. So again, one can tailor the immunosuppressive regimen according to the risk profile of each patient rather than adhering to a fixed protocol-based regimen. And one of the more important outcomes which severely affects long-term survival in transplant recipients is the development of de novo malignancies, which is related to immunosuppression exposure and also to the intensity of immunosuppression. Now, once malignancy occurs, immunosuppression may also contribute to its progression. And there may be multiple mechanistic pathways, which falls broadly into a few categories, and these include impaired immune surveillance and also infection or reactivation of some of the oncogenic viruses. In the table here are a list of factors which increases the risk of certain malignancies after liver transplant. For instance, alcohol and smoking will increase your risk of lung, head and neck, and also upper GI cancers. if you have underlying PSC and inflammatory bowel disease, your risk of colorectal cancer is increased. High age and male gender, etc., will increase your chance of developing skin cancer in the long term. And of course, Epstein-Barr virus status is directly associated with the development of post-transplant lymphoproliferative disorder. So the incidence of de novo malignancies in transplant recipients is roughly about 2 to 4 times higher than in the healthy population. And the malignancy-related mortality is becoming the most prevalent cause of death amongst transplant recipients. And the most common malignancies includes PTLD and also skin cancer. For other types of malignancies, there's often a high variability reported, and that is due to the different population that is studied and also the heterogeneity of the data source. For instance, head and neck and upper GI malignancies after liver transplant have a much more high prevalence or incidence in patients transplanted for alcohol related liver diseases. Now, this is in a large study, a recent study from France of over 11,000 adult liver transplant recipients. It shows that the probability of developing a de novo malignancy was 2% in 1 year, increasing to 13% at 5 years and 28% at 10 years. Significant risk factors includes recipient age, male gender, the type of initial liver disease such as alcohol-related liver disease and also PSC. And of note, the initial immunosuppressive regimen used had no significant impact. The most common malignancies were hematological malignancies, 22%, followed by non-melanoma skin cancer, 90%, and lung cancer, 12%. And looking at several large registries reporting on de novo malignancies, one can see that PTLD appears to be by far the most common malignancy development after transplantation across these different registries. For PTLD, you can see that the risk after transplant is lower in lung and pancreas transplant, but higher than heart and kidney transplant for liver transplant recipients. And as you know, PTLD commonly results from de novo infection or reactivation of latent EBV. The risk of developing PTLD from EBV is highest with a primary infection. And other well-established risk factors include the intensity of induction immunosuppression and also the duration of maintenance therapy and also the number of rejection episodes. There's also strong evidence that specific immunosuppressive agents may be at a higher risk of developing PTLD, and these include ATG, OKT3, tacrolimus, and some of the not so established perhaps is mTOR inhibitors and cyclosporin, and whereas mycophenolate basiliximab induction shows no increase in risk with PTLD development. And on the right side, and you can see that that this is another recent study looking at PTLD. The onset of PTLD is much more earlier for pediatric patient age group than in adults. And in fact, most of the PTLD occurs in the first 5 or so years. And this is likely due to the fact that this is the period where the immunosuppression is going to be the highest. Overall, though, it is likely that the overall immunosuppressive state is the strongest promoter for driving the development of PTLD. Now, for patients who are transplanted for alcoholic liver disease, the risk of de novo malignancies is much higher and in large part responsible for the reduction in long-term survival. And this is particularly true for smokers, whereby the risk of malignancies is markedly increased. And in fact, some transplant programs will require patients to quit smoking prior to consideration for liver transplant. And in the study of over 350 patients transplanted for alcoholic liver disease, the cumulative incidence of solid organ malignancies after transplant was about 8.7% at 5 years, increasing up to 33% in 20 years. You can see that tobacco use was associated with a markedly increase. If you look at the types of immunosuppression, it appears that the use of mTOR inhibitors was associated with somewhat decreased risk. Now, in another single center study of, this is over 1,600 patients, the most common types of malignancies were solid organ tumors, followed then by skin cancer and then hematological malignancies. Those mainly treated with tacrolimus had a significantly low risk of developing a solid organ tumor compared to cyclosporin. After multivariate analysis, history of smoking, predominant use of cyclosporin, and the recipient age were independent significant factors for developing solid organ tumors after transplant in this particular study. And this is a study of over 89,000 liver transplant recipients using the SRTR database, and just over 3,800 developed de novo malignancies. In this study, all the major immunosuppressive agents were associated with increased risk of developing malignancies. After multivariate analysis, immunosuppression containing CellCept, cyclosporin, sirolimus, steroid, and also tacrolimus were independent predictors for the development of the solid malignancies. So rather than some agents being protective of developing malignancies, it is probably more likely that some agents, such as CellCept and steroids, have relatively less risk in comparison with the other agents. So does getting off immunosuppression reduce the risk of malignancy then? When they compared patients on standard immunosuppressive regimen to those who were weaned off immunosuppression and then achieved operational tolerance, and those that didn't achieve tolerance, they found no de novo malignancies in the tolerant group versus 4.6% in the non-tolerant group and 13% that were maintained on standard immunosuppression. So it would appear that getting off all immunosuppression will significantly reduce the risk of malignancy. But again, this will only be applicable to those that achieve operational tolerance. Now, this slide just shows you an example of screening protocols for de novo malignancies in liver transplant recipients. I won't go through each of these components individually, but as our liver transplant patients are surviving for longer and many are reaching into the older age group, screening for de novo malignancies becomes a vital part of the long-term management, especially as the majority will still be on some form of long-term maintenance immunosuppression. The chances of them dying from rejection or recurrence of primary liver disease becomes minimal, whereas the risk of dying from de novo malignancies will be increased significantly in the longer term. And moving away from de novo malignancies, one of the other long-term effects of immunosuppression, and perhaps not as much talked about, is its effect on our bone health. And of course, there are multiple factors which may contribute to the reduced bone mineral density before liver transplants, such as cholestatic liver disease, alcohol, steroid, and so on. Now, risk factors for developing fractures after transplant includes a history of vertebral fractures, older age, type of liver disease, and also retransplantation. And immunosuppression also contributes to the development of bone loss and fractures. Of course, steroids have the highest rates of fractures, especially with high doses. And in addition to steroids, other immunosuppression, such as calcineurin inhibitors, are associated also with the loss of bone density. And with a reduced GFR, increase in phosphorus, this may lead to increase in parathyroid hormone and also contribute to an increase in bone turnover. So it is important to monitor for bone mineral density using DEXA scan. Currently, I don't think there's a consensus on the frequency of surveillance for bone mineral density, but for patients with risk factors and a normal initial bone DEXA scan result, I think repeating a test after 2 to 3 years to exclude significant bone loss would be a reasonable approach. I will finish off talking briefly about COVID and immunosuppression because we are still in the middle of a pandemic and it can affect liver transplant recipients receiving long-term immunosuppression. The mortality appears to be higher for those transplanted for more than greater than 2 years. So it raises the question of whether longer immunosuppression exposure may be a factor. Now, in a recent study published in the Journal of Hepatology on COVID and liver transplantation, the study identified several independent risk factors for severe COVID-19 hospitalized patients. These includes the Charlson Comorbidity Index, male gender, shortness of breath at diagnosis, and also baseline immunosuppression containing mycophenolate. And the Kaplan-Meier curve illustrates the negative prognostic impact of mycophenolate, especially at a dose of more than 1 gram per day. Whereas in contrast, calcineurin inhibitors, mTOR inhibitors, and maintenance corticosteroids were not associated with an increase in risk of severe COVID-19. And in fact, in the study using the European Registry, the use of tacrolimus was associated with a better survival. And this may not be too surprising, as studies have shown that CNIs can block the replication of human and animals SARS-CoV virus in vitro. There's not a lot of data on the use of steroid, although there has been a lot of interest in the use of dexamethasone, showing a lower 28-day mortality in persons with severe COVID. So steroids may have some benefit in subgroups of patients. Overall, the management of immunosuppression for transplant patients infected with COVID has been quite variable, although the overall tendency is to reduce immunosuppression, especially those on an anti-metabolite drugs such as mycophenolate. So to summarize, the overwhelming majority of liver transplant recipients will be maintained on immunosuppression with only a handful achieving operational tolerance. So therefore, clinicians should be well aware of the long-term impact of immunosuppression, especially as patients are now surviving longer. The impact can be broadly divided into class effects such as opportunistic infections and also the development of malignancies, whereas the more common individual drug effects includes renal toxicity, metabolic diseases such as diabetes, hypertension, dyslipidemia, and obesity, and also bone disorders such as osteopenia and also osteoporosis. Protocol-driven immunosuppression regimens are outdated and they should be individualized, taking into account the patient's risk profile so that the long-term detrimental effect of immunosuppression can be minimized, but at the same time without compromising on the long-term graft viability. One should aim to use the lowest dose possible to prevent rejection, thereby avoiding the development of associated adverse effects that we have just discussed. And last but certainly not least, all liver transplant patients should be regularly screened for the long-term effects and impact of immunosuppression. These include disorders such as diabetes, dyslipidemia, osteoporosis, malignancies, and also have a high index of suspicion for opportunistic infections, cardiovascular, and cerebrovascular complications. So I will finish here and thank you very much for listening. And also I would like to take this opportunity to extend a warm welcome to you all to the next CAST meeting, which will be held in 2023 in Hong Kong. And hopefully we can all travel by then and you will be able to come and visit us. So thank you very much.
Thank you, Dr. Fung, for giving us a nice talk. And is the questions answer is allowed or it is not allowed?
Yes, sir. Yes, sir. We can ask the questions.
So
after each talk, we can.
Dr. Fung, can I ask you as a moderator first question, start the ball rolling, that we know that long-term immunosuppression has various high propensity to develop malignancy in a recipient. And there are various forms of malignancy. What I am interested to know is the number of immunosuppressants as well as the doses of immunosuppression has a direct correlation with the onset of malignancy. For example, maintenance only with TAC. Many patients you can maintain with TAC on long term. Simple, and steroid withdrawal is usually done at 3 to 4 months. And in contrast, some people may need both CNIs, maybe mTOR inhibitor, or maybe other inhibitors like EJA or CellCept. And is there a difference between various combination and the doses of immunosuppression as far as long-term malignancy is concerned, as well as long-term metabolic syndrome and renal disease? These are the three major Achilles heel on long-term immunosuppressants.
Thank you for your very good question. In fact, it is the Achilles heel, those metabolic syndrome and also the de novo malignancies. Certainly the types of immunosuppression, the intensity and the duration of immunosuppression is related to the development of de novo malignancies, especially with hematological ones. In fact, the majority of patients in these studies, long-term studies, they will especially if they're protocol driven, they'll be actually on minimal immunosuppression after 3 to 4 years. And most of our patients will actually be on perhaps low dose maintenance tacrolimus. And these patients will, down the track, will still develop de novo malignancy. So as a class effect, it is probably just the overall decrease in immune surveillance, which is attributed to the increased risk of developing the solid organ tumors. Of course, there are some intrinsic diseases which may be associated with heightened malignancies, such as those that are transplanted for alcoholic liver disease. I mean, they certainly, especially if they continue to smoke, and if they relapse and drink, then their risk of head and neck cancers and also upper GI cancers are much more increased. In terms of the different types of immunosuppression, I've showed you that lovely meta-analysis, in fact, that all of them actually had an increased risk of developing long-term malignancies, which is, just a whole overall class effect, but some certainly more than the others. And agents such as CNIs were shown to be a bit more than perhaps steroids and mycophenolate, which is actually in essence an anti-metabolite or agent, or maybe anti-neoplastic. It's used previously in its early days. So there are some differences. In terms of metabolic syndrome, again, some of these factors, the degree of immunosuppression is going to matter. And the types of immunosuppression some of them will be associated more with certain agents. In terms of things like renal impairment and trying to get off, and will it improve? That little study I showed where they were able to achieve operational tolerance, none of that particular group developed Novo malignancies that were successfully weaned off immunosuppression. So that may be just a hint of, that if you are able to get off immunosuppression completely, then you were able to reduce. Of course, it's not going to be zero for life. It's going to come up, at one stage or another, but it's going to be much lower. In terms of renal impairment, I think that's probably been overstated in the past, perhaps, because by the time you can get off immunosuppressant and achieve operational tolerance, these are patients who are 5-6 years down the track. And by that time, the renal impairment's already well established, and there's not much degree of reversibility, even if you get off those. I mean, you and I know that, our patients who have creatinines of 150, 200, even if we've minimized them and get them off immunosuppression, we can see that their renal function continues to deteriorate. So that's kind of, for that, it's probably, that's probably not going to be too much effects from trying to get off immunosuppression in terms of the renal function. But, we still tend to do that.
Thank you. Is there any, I don't see any questions in the chat box. Is there any questions from moderator, because I don't want to waste time?
Yes. Dr. Acharya, can I ask a question? Hi, good evening. Thank you, Dr. Fung, for that nice talk. I had a very specific question that we use mTOR inhibitors as for their renal sparing effect. Now, if you have a patient with early diabetic nephropathy who's been transplanted, has a borderline creatinine, would it be, and he obviously has some proteinuria because of the diabetes, would it be safe to use an mTOR inhibitor in a patient like this, or would you rather go with TAC? Because this is we see a lot of diabetes. India, as you know, is a diabetes capital of the world, and we have this kind of scenario pretty often. So what would you do?
And there's an excellent question, actually, and it's all with immunosuppression is always about, I think, balancing the risk and benefits. For those patients with significant proteinuria, I think it'll be very tough to use mTOR inhibitors as a renal sparing agent, and you would probably look towards other agents such as mycophenolate in those cases as a renal sparing agent, because if they have significant proteinuria, then a lot of them will end up having significant peripheral edema, and they tend not to tolerate even the lower doses of mTOR inhibitors. So the renal sparing benefit may not be so definite in this particular group of patient. In those with mild, microscopic, microalbuminuria, I mean, you can monitor the patient and see whether they'll end up with having significant proteinuria or have increased proteinuria while they're on the mTOR inhibitors. That's one way of individualizing the approach. But if they have significant proteinuria and renal impairment to start off with, then I'll be very cautious about putting those patients on mTOR inhibitors.
Thank you.
Thank you. If there are no other questions,